introduce the speakers, but she is one of them, and Dr. Nutter is another. So please take it away. Thank you so much.
Thank you so much for having us here today. We're thrilled to be able to take part in grand rounds and share about nursing impact in global health. And we're really going to speak about our experiences in partnership through education, research, and advocacy. As Dr. Rutherford mentioned, I'm the director for Center for Global Nursing. I'm lucky enough to maintain my clinical practice as a nurse practitioner in pediatrics, in neurosurgery and critical care on both of our campuses. I love my jobs, and I get to be an assistant clinical professor at our School of Nursing, and I'm the nursing lead for our WHO Collaborating Center on Emergency, Critical, and Operative Care. And later you'll hear from the wonderful Dr. Nutter, who's an assistant professor at our School of Nursing in the Family Healthcare Nursing Department, and is our Sigma nursing representative to the United Nations. I got it, I know it. There you go. Okay, so I think before we dive into our partnerships and our contributions to global health, I think we should take a big picture look at nursing and global nursing and what some of the impacts and the challenges are, and even the opportunities. We know that no global health agenda can be realized without a concentrated focus and effort to maximize the contributions of the nursing workforce. They represent the largest member of our global workforce at 59%, 20 million nurses across the globe. And this requires us to think about this in real time and create policy and interventions to maximize nursing scope, raise them into leadership, and alongside just really an accelerated investment in education, skills, and jobs. In order to achieve the Sustainable Development Goals, in order to maximize impact, nurses need to be part of the conversation and an integral part of our multidisciplinary team. This is an image from the WHO, just like really pointing out that nurses are central and they impact patients at almost all points of care delivery. They're necessary to provide universal health coverage. They're required, like they're needed in emergencies, epidemics, disasters, primary care, midwifery. We need them. And in order to address the Sustainable Development Goals, they must be a part of the solution. And they're really good at looking at social determinants of health in order to increasing access to care for vulnerable populations. The global nursing workforce faces many challenges. And I would say that as a nurse in the world, I'm so proud of my profession, but it is not always easy, and the journey is not always, there's not always the most opportunity for nurses, especially for our partners in LMICs. So the world does not have currently a strong enough global nursing workforce to achieve our Sustainable Development Goals. And when we think about it, and at UCSF, we always say, we have a shortage of nurses. We have a shortage of nurses. And when I look at this map, I'm like, yes, maybe we could be better. But 80% of the world's nurses are found in countries that only account for half of the world's population. When we look at in this map, I mean, it's similar to other disparities that we can point out and we can see in terms of surgical access, midwifery access, but nurses alone in our LMICs, there's not enough of them in order to meet the needs of the population. We also know that nursing creates compassion and a healing environment, and that impacts health outcomes. But nursing is not just an art, it's a science, right? And we need intelligence, we need skills, we need knowledge, we need critical thinking, and that requires high quality education. And there's so much data on this that's very fascinating. I looked at a lot of this years ago, but it continues to be published that there's a shortage of qualified faculty, particularly in our low and middle income countries. They lack resources for faculty development, learning teaching methodology, how to do simulation, how to train with the evidence that they have available to them that's relevant to their area. We also know that when nurses train here in the United States, there's a certain amount of clinical hours that they have to do to apply their learning to show and to learn how to use what they've learned in the classroom in patient care. So when they jump into their job, they know what they're doing. And same with residency for physicians, it's a similar model. And when we look at the hours that nurses have in practicum sites across the globe, there's so many disparities and so many limitations for nurses gaining practical experience before they're pushed out into the job. And then one of the most interesting concepts, I think, in nursing education, and it really ties into all the stuff we're doing towards decolonizing global health and equitable partnerships, is when we think about the knowledge to practice gap, which is really as defined as we teach nurses what's in the textbooks, what's in the best evidence, but where does the evidence come from? It's coming from high-income countries. So if I teach a nurse, where have I worked? Let's go to Haiti. If I teach a nurse that to perform a Foley catheter placement, I need to don sterile gloves. I need to get sterile equipment. I need betadine. I need X, Y, and Z things in order to complete a procedure. And they're like, okay, I understand that. And then they go to the hospital, and there isn't sterile gloves. There isn't sterile catheters. How do they practice? And it really leads to a lot of challenges for nurses in confidence, lack of standardization of care, and not optimal outcomes for patients. Another thing to think about is nursing titles. A nurse is not a nurse, and nursing training is not the same no matter where you go in the world. There's a lot of programs that I've worked with nurses all across the globe where you can go for a 6-month training and you're a nurse. But that is very different than our doctorally prepared nurses. So we have nurses that are trained to do bedside cares, and we have nurses that are trained to prescribe and critically think. And when you meet nurses, when you interact with nurses, it's really important to understand that not every nurse has access to the same education. We found this out in Laos, one of the countries I've been working in. They wanted to make sure everybody had the correct certification, but this was years after we started our hospital. And we found out that our most talented nurse, the one who's our nursing director, had a technical degree. But when we started the hospital, we didn't understand all the different degrees, and so we didn't screen for that or understand that. But this woman is amazing and has taught herself so much, but it's important for us to just understand that. And when we go to a country and we partner with them and we say, why don't you understand like that when I touch this here, right here, that's connected to your heart? You have to understand that that is not taught in nursing schools everywhere. And so really understanding those challenges in education is really important. And then specialized training, when we look at who is working where, same thing here. A lot of papers pointed out that nurses working in critical care, which is a very specialized service across the globe and not in every country, is fully developed. There's diploma nurses, which similar to like an associate's here, it's a 2-year degree, but those are the people working in critical care, taking care of patients. So these are just some big things. Keep in mind when you think about global nursing, it's a lot going on. And there's a lot to share and a lot to learn from, especially from our partners. In my journey as a US-based nurse, I was trained in Canada actually, but came back home to the US and knew my whole life I wanted to do global health and knew I wanted to work in a hospital, and I worked 36 to 40 hours a week for the last 20 years. How do you build a career in global health doing that? And I think that's one of the biggest challenges is how I've been lucky enough to work in 20 countries and help build critical care and surgical services. And Jerry will share with you the pathway for nurses in academia getting involved in global health. But I want to say that nurses here at UCSF have a real challenge getting involved because they have clinical obligations. I don't know if you guys know what's going on in the medical center, but we're short nurses right now. And everybody's working overtime. So we know we want to partner. We know we need to elevate the practice of nursing. We want to contribute to the development of nursing all across the globe. Like, how do we do that? And I would tell you that my journey was a lot of quitting jobs. I left my job at Lurie Children's Hospital as a nurse practitioner in the ICU to go work for Partners in Health and move to Haiti because I was like, hey, this is my dream job to teach critical care in a country that I love with people I love. And so quit jobs, worked as a travel nurse, all that to be said. Then we sit back and we're like, well, UCSF is pretty amazing. And we have what do we have? More than 4,000 nurses here and more than 800 advanced practice providers, which are our nurse practitioners, our PAs, our midwives, our CRNAs. And we have these amazing people. We have with great skills and actually a lot of interest. And thank God for our amazing leaders who listened to Rebecca Silvers when I decided to knock on their door. George Rutherford actually was in the interim position at the time, and we said, we need a place. We need a place to harness the amazingness of our faculty at the School of Nursing and our Kimbot cells of the world. And we need a place to provide space for our nurses to grow and to provide opportunities for them to get involved in global health sciences. So we have the Center for Global Nursing, and please join us at 4 p.m. for celebrations. But back to partnership and education. And we were going to separate this, but really you can't do partnership separate than education. And we all know, those of us that have been working with the Bixby and the IJHS Equitable Partnerships Initiatives, we know that partnership is the key to success. So let me take you to Laos for just a minute. My partners would have joined us for this, and I invited them, but it is 2 a.m. in Laos. So they said, Rebecca, you go ahead and you share. So I just want you to know that they wanted to be here, but it is not a good time. So Laos is a really small country, landlocked in Southeast Asia. Population in the Luang Prabang province, which is up here in northern Laos. It's 450,000 people, 12 districts, 752 villages. They've got a provincial hospital, 12 district hospitals, and 80 community health centers. What's missing in there is specialty pediatric services. And if you know Lao at all, you know that it is mountains, it is forests, and it is hard to traverse this country. It looks small, but it is a long drive to get anywhere you want to go. So luckily enough, the Ministry of Health partnered with a nonprofit called Friends Without a Border and built the Lao Friends Hospital for Children and opened its doors in 2015. They see 38,000 patients annually, have 13 departments. It started small. It started as OPD, outpatient, and then got inpatient, and then opened an emergency room, and then we opened NICU, and then there was an OR, and now there's an HAU, which is essentially a pediatric ICU. They've got a lot of neonatal beds. They've got 52 pediatric beds and an incredible team of people. As the hospital has grown, so have their numbers. When I think about 2016, there was 11,000 outpatient visits, 3,000 emergency room visits, and 191 surgeries. 3 years later, 24,000 outpatient visits, I think it was 11,000 emergency room visits, and 1,200 surgeries. So through building capacity in nursing and in the other fields that we're going in physical therapy, medicine, laboratory, et cetera, they were really able to increase access to service and care for children, and they provide free care. But these are the amazing nurse leaders that I'm lucky enough to know and have worked with since they were new graduate nurses, and they're now just champions in their field, and I'm so honored to work with them. Molly is the nurse in the middle top left picture. She's our nurse director. Seeley in the right picture is a nurse anesthetist, now nurse educator. He's in charge. We have 6 nurse managers, and they have 17 nurse leaders. And I just wanted to talk about education for this hospital because we've seen the success of this hospital. They went from new graduate nurses to being an independent nursing group. They're running it. They don't need me anymore. I come and visit. It's social. It's great. We do some quality improvement. But years ago, they needed to learn that this was connected to this, and they didn't. And we spent a lot of time talking about it, and it was real fun. But they were lucky enough to have dedicated time to education. This organization, the Ministry of Health, knew that if they wanted specialty services, we had to train. And they got 8 hours of dedicated time a month for 5 years. They also got English classes to help them learn to understand and work with the clinical mentors that were brought to work at the bedside. So they had volunteers coming from 2 to 12 months at a time to work with them at the bedside, helping them apply the didactic learning to what was at the bedside. And you know, when you do these kind of grassroots, nonprofit organization education programs, like nobody evaluates them. But COVID, that was a great time. We were like, okay, well, we have no more clinical mentors on the ground. The Lao staff said it felt like training wheels were taken off before they wanted them off. But man, did they ride that bike. And they're doing it so well. And it was great to actually have all those clinical mentors pulled from the bedside. And the Lao staff learned the possibilities and the greatness that they can, of the care that they can provide. So we just did a quick evaluation. We reviewed the curriculum. We did interviews with the leaders that helped build the curriculum, and we said what was important and what made this successful. And in the word cloud is some of the key themes that came out. They wanted it to be a multimodal teaching, Lao-centric, empowering, adaptable, collaborative. It was really important that play was involved because in their culture, play is a really helpful way to learn. They focused on implementation science and train the trainer, so many things about understanding the beliefs, completing the needs assessment, all the things that we think about. And then what was exciting to see from the perspective of the clinical mentors that were at the bedside over the years was that the skills that these nurses acquired over the years increased in complexity. They were able to go from task-oriented to critical thinking. They manage ventilators now. They're in charge. They're amazing. And beyond that, beyond the acquired skills, they were able to establish nurse leaders and empower nurses, which is pretty amazing. And just one quick other thing about our Lao Friends Hospital for Children is that surgical care, which we just got to present about at the Global Initiative for Children's Surgery Conference in the Philippines 2 weeks ago, is only possible because of nurses at this hospital. 7 cases a week on average, 4 to 7, with 4 nurse anesthetists and 3 scrub nurses. The scrub nurses are not what we have here. They first assist, they close, they manage those gastroschisis babies. They do amazing work. And so they contract with adult surgeons at the provincial hospital to come over and work with them because there's only one pediatric surgeon in all of Lao. The second pediatric surgeon is currently being trained, and he's Dr. V. He works for Lao Friends Hospital for Children and will be coming back when he's done with his training in 2 years. So we're really excited for that. But right now, this is a nurse-run OR. And this is the cases that they've created accessibility to. Through education, through their training, they now manage orthopedic patients, abdominal surgeries, inguinal and hydroceles, abscesses, dressing changes, lots of traumas, lots of burn in terms of their global burden, in terms of their burden of disease. And this is just a pictures, because I just love these people with all my heart, of Noi, Vandy, and Dr. V all got to join us in the Philippines to share about creating access to surgical care in Northern Laos for children. It was pretty amazing, and we met with all the surgical nursing teams from across the globe. And one last thing I wanted to talk about when it comes to education, because we know that COVID changed how we partner, how we help elevate education practices. And I was lucky enough to be involved with the Ghanis Nurses Foundation and Corley Blue Children's Hospital and Yale New Haven Children's Hospital's medical staff, because they've been teaching doctors in this hospital in pediatric critical care for so long. And they were like, well, why don't the nurses get any education? They've never, ever, ever had critical care education, but they're critical care nurses. And so they said, can you help us? And we said, great. And this was before COVID. And we're like, well, come, we'll do a needs assessment. We'll figure this out. And then COVID. So we're like, okay, what can we do? Let's try something and let's evaluate it. So we did a distance-based education program every other week on Zoom for 2 hours. I woke up at 4 a.m., taught every other week. We did an anatomy, physiology, pathophysiology, management, and treatment based on the LNA, based on the extensive learning needs assessment that we created. And every other month, we did a VRR session, which I'll explain what that is. It's virtual recess room, so simulation, where we had an external person monitor and evaluate the performance, and then we got feedback from the nurses. So VRR is, if those of you that have never heard about it, virtual recess room is an online, really great because it doesn't need high-speed internet simulation training. So it uses Google Slides and Zoom, and everybody can come together, see each other. In this Google slide, you have a patient, you've got equipment, there's vital sign things, so the nurses can bring over the oxygen, they can bring over the temperature, they can bring over the electrodes, you can measure their vital signs. And so we practiced all the things we were learning in the classroom and the didactic training here in these simulations. If they want to see capillary refill, or if they want to listen to the lung sounds, I can flip you to a slide and show you the visual. It's a pretty amazing technology to allow us to provide simulation when we need to do distance-based education. And just some small results from this. We saw some increase in teamwork over time, increase in decision-making, and especially prioritization of care. And we saw better transparent thinking and orienting to new team members within these simulations. The nurses gave amazing, really valuable reflections in the SEM tool, and they said that this training was really relevant for their PICU in Ghana. I think taking the time for the learning needs assessment really allowed us to cater it to exactly what they need with the tools that they have in their hospital. They felt that the simulation training was a useful tool for clinical learning, and we were training the trainers so that they can run these on their own, and that through skill acquisition, they felt more comfortable in clinical decision-making in real time. So we thought that this was a pretty wonderful piece of work to share. So global nursing education, so much, we could talk about this for days, but through education and training, nurses can increase their impact on population health. We know they're already impacting them. In order to increase accessibility to high quality care, we have to prioritize nursing, and we have to think about their education because it's not universal that they're getting the quality education that they need. We know that the lack of relevant education and poor quality education leads to decrease in confidence, lack of standardization. And we know that partnerships are a great opportunity to help with solutions, local, regional, or global. I know at UCSF we love partnering with all the people, but the amazing thing about being at the GICS conference with the nurses from Laos was that we could connect them to the Vietnamese team. And they were like, oh, come to, they're an hour away from each other by train from Hanoi to Luang Prabang. So it's like, how can we connect you guys so that you guys can work together, so that you can grow together, and so that nurses can feel connected and empowered and grow. Now I'm so excited to hand this over to Dr. Jerry Nutter to speak about research.
All right, thank you so much, Rebecca, and thank you all for joining us this afternoon. So my name is Jerry. We'll start from here. Yeah, so I'm Jerry, and as mentioned, I'm assistant professor at Family Healthcare Nursing Department, and also I represent Sigma Nursing, which is the second largest nursing organization to the United Nations. So when we talk about research, I want to mention that the School of Nursing or faculty within the School of Nursing are involved in several research projects across the globe. And there are some global health work also happening here right in the U.S. So global health research, as we know, is not only about going outside the United States or the country in which you are living in, but there are a lot of global health work also happening here. UCSF School of Nursing is number one NIH-funded public school of nursing in the U.S., and a lot of this funding also are supporting global health work, and several of our faculty, I don't want to mention them, but because I may miss some people, there are a lot of us involved in global health work. And I also want to mention that we have the WHO Collaborative Center, which Rebecca and others are also managing here at UCSF. So when it comes to global health work, I think UCSF School of Nursing faculty and researchers are involved globally in a lot of this work. I want to also mention my personal research, or just because there's so much to talk about research as it comes to the School of Nursing faculty here. So I want to just focus it a little bit on mine and what I do, so I can give you a sneak peek of what I do in global health work. So I've been involved in HIV work a little bit when I was in Ghana after my high school. I was a peer educator for HIV prevention. Then we were doing that work in our high school, and also among traders, drivers, long-distance drivers in Ghana, educating them on HIV prevention. When I moved to the U.S. in 2013 for my master's program at UC Davis, and then I was there, I moved to Drexel for my PhD, and then did a postdoc at Princeton University in global health and health policy. So at Drexel, there was a program there called the DONSAF Global Development Program, which was actually recruiting students and send them to a country in Africa to work on water. I work with World Vision, sorry, I forgot that a little bit. World Vision, as some of you may know, is involved in water hygiene and sanitation project across several developing countries in the world. So I was recruited not knowing where I was going. I think a month to the departure, I was told that I was going to Zambia. I was going to Zambia. You go there without having a project in mind, and you work with the people in World Vision as well as people who are actually on the ground on water hygiene and other projects that they're working on. So when I got there, I started discussing with a lot of people. I shadowed some of the nurses. I went to some of the hospitals and clinics, and I realized one thing, that at that time there was drought in Zambia, and also I saw that a lot of patients that were coming to the pre and postnatal clinic were actually not adherent to their HIV medication. So I started questioning and asking questions, and I realized that some of them were experiencing side effects around gastrointestinal problem, which was a bit of problem for them to take the medication. So when I came back, I decided to focus on this research and see how we can understand access to water, toilets, and other things in the face of adhering to HIV medication. So that is what my research actually really focuses on, in addition to other things. And sustainable. So when coming back, we know that we have the Millennium Development Goals, and then followed by the Sustainable Development Goal. The UN and other organizations saw the need for this, and Goal 6 is generally dedicated to water hygiene and sanitation. And when we talk about these goals as well, we look at them such that not only Goal 6 that is related to water hygiene and sanitation, but also we know that there are other goals such as ending of extreme poverty, fighting inequality and injustice, and fixing climate change are all related to water hygiene and sanitation. Why do we say this? We know that in most developing countries, I'll talk about African culture, when the women are more of the people who are responsible for fetching water and taking care of water and other things. So when there is no water in the problem, it is in the house, it's more of a women problem or girls problem than everybody's problem. So when we focus on this, we are also actually working towards fixing the other goals or helping to meet the target of the other goals. And so I started first looking at adherence intention. When you are a physician or you are a provider here, healthcare provider, whenever we actually seeing a patient, we have to know that there are two experts there in that room. You as the expert on providing care or the medicine or nursing, and then the patient as experts on their own life, how they handle their life. So whenever you give a prescription to a patient, it is up to them to decide whether to take it or not. In most cases, they can default, and it can be intentionally or non-intentionally, or where they decide to do that or not. And when I was in Zambia, then looking at this, I saw that there was a little bit of unintentional kind of non-adherence, where people were not really they really wanted to take the medication, but due to lack of resources such as toilets and water, because if they take this medication in the evening, they don't have toilet at home, the water is not flowing, it was a little bit of difficulty going to a public toilet to use that, so they were actually declining. So I actually look at adherence intention, or ART adherent intention in the face of access to water and toilets. So we also know emerging gap in the public health issues across Africa is decreasing resources. And we know climate change. I don't think I'm going to be the one talking about how climate change is going to be affecting Africa, which is contributing less to the climate change. They are the ones that are going to suffer the most. So based on that, I conducted a study focusing on adherence intention and how water and toilet access actually impact that. I don't want to go into a lot of the result. I just want to provide this. If you want to read, you can see the result here. But the basic thing we found out here is that women who have access to water often and toilet in their home were more likely to have intention of adhering to their HIV medication compared to those who do not have water at home and do not have toilet at home. And that's the basic of that. So because I did that for my PhD dissertation, looking at intention, when I got here, I decided to move in to look at adherence and water insecurity. So in this one, I look at it also again among pre- and postnatal women in Ghana, looking at how access to water and food actually impact adherence to ARTs. So, and then we found that women who have experienced water insecurity were less likely to adhere to their HIV medication. In our sample, we found that food insecurity was not associated in our sample, and we actually linked that to maybe the small sample size that we use for the sample. And we writing an R01 now, and then we met with a program officer who was saying, why do we even have to consider water insecurity outside of food insecurity? And we met with two program officers, and I explained this to them. I was born and raised in a very, very rural area in Ghana, and we were actually peasant farmers. So throughout the year, we have food. Right, we have food from January to December because we can store grains and eat them even in and out of farming season. But water was a big problem for us because we couldn't store water for 12 months or for 6 months. So we can't just think that water insecurity and food insecurity are the same. And I think we published that in the PLOS Global Public Health, that people can actually also read that if you're interested in the findings. And I also want to mention, this is just mine, but there are a lot of research happening in the School of Nursing, which is focusing on global health and other water and insecurity or food insecurity. And beside this, I also organizing, when I was finishing my PhD program, I saw this lack of conference organizations as it happened, so very, very unequal, that a lot of research happened in sub-Saharan Africa, but conferences happen in developed countries. So IAS that happened last year, we saw that a lot of Africans were denied visa to attend this conference. When we talk about the region that is most burdened by HIV in the world is Africa. However, Africans were denied visa, majority were denied visa to attend conference. And we've presented this finding in these conferences, and the people who actually contributed to this study do not even get to hear this, because sometimes we publish them even in subscription journals, and their libraries don't even have subscription to this, some of these journals, and it become a problem. Sometimes I have to download papers, maybe, and then share with my collaborators because they couldn't access them. So I thought about how do we have a conference focusing on interdisciplinary health, and doing that in Africa, rotating it so that it can be cost effective and can be easily accessible for people in sub-Saharan Africa. So I started that in 2018. We've been having that since then, and the 7th one is happening in Johannesburg with University of Witwatersrand this year. In addition to that, we have decided one of the things is to do a pre-conference training. We last 2 years, I reached out to the UCSF CFA and the ARI, and they have been supporting us with a pre-conference training. So last 2 years, I think Patience Fulani and some others help us training people on qualitative research method. Last year, we hired somebody to teach, to train people on manuscript writing, and some of those people submitted their first authored publication. And this year as well, we are doing that because CFA and ARI are still going to be supporting us to do the pre-conference training. And this year also the Center for Global Nursing is giving us some support in organizing this conference. So if you have collaborators in Africa, I strongly encourage you to let them submit abstract. We are going to extend the submission to the end of March. And if you can, I will encourage you to support them to attend this conference, because most of the time they are not able to come to the US, Canada, and all the developing countries because of the cost and also visa. So advocacy, as I mentioned, I represent Sigma Nursing at the United Nations. So one of the things we do here is how do we educate nurses on the SDGs and also communicate that between the ECOSOC, the Economic and Social Committee of the United Nations, which is one of the charters. How do we communicate that with our nurses and work with nurses also towards advancing and achieving the targets set in the Sustainable Development Goal? And I've been doing that with 6 other colleagues across the world. We represent Sigma at different event and organize meetings, and also bringing the information to them and also from them as well. And then last year I was at the United Nations General Assembly the UNGA 78, where I delivered an intervention on how we can involve nurses in the fight against tuberculosis, because nurses are the majority of healthcare providers that take care of people who are suffering from tuberculosis. So we can take them away when we are drawing policies and way forward and how to proceed with ending the tuberculosis. All right. Also, beside that, I do with with the help of some people and also the ARI, because I'm an ARI diversity scholar, we organized a book drive. I went in Ghana in 2022, and I saw a lot of nursing schools. Nursing schools were lacking books. So I did a book drive, and I collected 1,000 copies of books, and I donated them to schools in Ghana, Rwanda, and Kenya. And these are some of the schools that I donated that to. These are all schools in Ghana. And the good thing is I'm still collecting the books donated by the School of Nursing faculty. And so many books. And now I've collected more than 900 copies of books again. And then we are going to be donating. And this one, you may see that picture at the left. I think that's Dr. Maureen Akola, IGHS faculty affiliation. She was here last year, so sent some of the book to her. And then she also donated to them in a school in Kenya, Western Kenya. And the other one was the former dean of the School of Nursing at University of Rwanda. I was there, and I donated a bunch of books to them as well. So we are doing that again this year, and then we want to donate to multiple countries. Books are very important, and we want to train nurses and other healthcare workers who will be prepared to face the challenges in Africa. So thank you so much for your attention. We will take questions. Yeah. Questions?
Where's the little? Well, whatever. Okay, well, I want to start by saying that I live, laugh, love Rebecca and Jerry, so I'm so excited that you guys can be here. And thank you both for your wonderful presentations. Does anybody have any questions? No. This one doesn't have like the little thing.
Oh. I think I can.
Okay,
Does
Alden's
this
gonna
work?
ask you.
Can you hear me? Thank you so much for that. Everybody knows I'm a nurse. I love what you're doing. Jerry's a colleague in the School of Nursing, and that was really wonderful, Jerry. We've co-authored a paper, but I still felt like I was hearing everything fresh. You brought up something that we've commiserated about a little bit, and that is, how do we get our government to understand our responsibility to our global partners as well? I know with NIH funding, it's quite difficult. We actually had a program manager say to our team when we submitted a grant, well, how will this benefit America for a global site? It was really demoralizing. So if you have any words of wisdom about that, or ways that together we can advocate for lifting nursing, the visibility of nursing in those sorts of settings, it would be very welcome.
Yeah, thank you for that question. I think, I see those challenges as well, that a lot of people, not just from the government, also some people internally also do not think that funds and things should go to Africa. We have to be clear about this and be upfront about them. Some people internal also don't think that way. But this is how I frame it recently. I said that, when I design an intervention in Africa for people living with HIV, we can adapt, when that intervention is successful, we can adapt that into the culture of the US and can help people. So just like how we can adapt intervention from here to a developing country, if it is a smoking cessation intervention or any sort of intervention, or anything that we are doing, the finding can give us some kind of idea into helping the problem back here at home. So that is one of the areas that we can think about, that how do we do that? How do we see the picture also as a global picture? Because if we solve if we solve the problem in developing countries, trust me, half of the American or developed country problem is solved. Right. If there is a better living condition, job creation, health is, everything is going well in developing countries. Developed countries will also equally benefit because all the problems may actually decrease in many ways that some of us can think about, not going into the specifics. So that's why we have to invest in developing countries and see how they live in good health, they have good job, they live in good condition if we can, so that we will also be free and enjoy our lives.
So in East Africa, specifically in Kenya, there's this whole class of people called clinical officers who are not part of the nursing track. They're more kind of like physician's assistants, kind of, 2 years of training. How do you see that extra cadre being integrated? Is that, how does that all fit together at the end of the day?
Yeah. So on the UCSF Health side, we have an Office of Advanced Practice. So we include, so when we talk about APPs on the health center side, it's, as I mentioned earlier, it includes physician assistants, nurse anesthetists, nurse practitioners, and nurse midwives. And I think at the US, in the US, the training is very similar to a nurse practitioner. I mean, there's even like UC Davis, they share classes, the PA students and the NP students, because they all have a master's degree and they're all advanced, practice providers. I think the challenging thing across the globe is, as you mentioned, the clinical officer training is very different. Nurses training is actually longer than clinical officer training. But I was just in Liberia working with clinical officers that are managing care independently in rural areas. Came to our the WHO basic critical care pilot, and they were saying how stressed they are managing critical illness at their level of practice when patients show up to clinic, and how these skills that we're training in BCC were really helpful for them. So I think it's something where the International Council of Nurses and the WHO are looking at how to integrate actually clinical officers into this world of nursing and advanced practice specifically, so that we can elevate everyone to optimize care for all. Because I think at the end of the day, there are not enough physicians to provide care to everyone. And so clinical officers, similar to physician assistants, similar to nurse practitioners in the US, are really meeting the gap and the need of the population. So we need to partner in order to help them elevate their practice, whether they need more training, whether we can advocate for higher qualifications. I think that's all potentially to come.
Yeah, and also to add to that, I think that's when we look at this problem also, it's I don't want to take anything from what Rebecca said, but also sometimes it's politically motivated, because the majority of the healthcare system in developing countries is financed by the government. So how do we get people who are half prepared in a way, we don't pay them so much money, and then we can hire them so that we can decrease expenditure. So we train people, and then we say, your training is not up to the level of the doctor, so we will not pay you that much. So some of this is also more politically motivated in a way to make sure that they decrease government expenditure on some of these things.
And it's really interesting because the pay and the politics comes really into it. I know that we were talking to the Ministry of Health in Sierra Leone and about nurse anesthetists, and they only offer a diploma in nurse anesthesia. Nurse anesthetists are leaving the field in droves because they're like, this was their example. They said, I can get a bachelor's in basket weaving and get paid more than I am as a nurse anesthetist. And so there's a lot of challenges. And so we're trying to help, support them as their team is building a higher level training program so that they can get a bachelor's, so that they can achieve that higher level of pay. Because what we're really challenged with, on top of everything I mentioned today, is nursing migration and people leaving in droves for higher paying, better opportunities. So yeah.
Yeah, thanks for this talk. It's really great. Congrats on all your work. Michelle Shang, I'm pediatric infectious diseases physician and malaria epidemiologist. I just had 2 questions on the adherence work that you did. Has there been any follow-up in terms of trying to provide clean water services, linked to HIV care? I'm just curious. Has there been any follow-up on that? And then it seems like it would be hard to to get that funded and that support through like HIV mechanisms. And then my other question was just about this dearth of nurses globally. And is there some consensus on like how many nurses there should be per population? And are you all, is there a big movement in creating new schools of nursing? Because it seems like as like a leader in, as a school of nursing, you know, in the US, that might be an area where UCSF could really partner. And then on the other side is creating the market for that. Like, is there any advocacy work being done to kind of like increase funds from the healthcare sector, from the government for nurses, or anyway, just to address these gaps? Thanks.
All right, so I'll take the first one. Rebecca, I'll take the second one. So the first one, yes, this is what we did. The World Vision provide water, hygiene, and sanitation services, and they kind of sort of funded my dissertation work. So I provided, they asked me for a written report. It's a summary of that. I did that to them. They're providing water and public toilet services in Zambia. So they're doing that. And also now we're working on another grant application, trying to see how we can do design an intervention to solve that problem. So that we are on that side at the moment. Yes, it's difficult to get funded. It went in first with some comment, and we are addressing them for resubmission. So yes.
Yeah, and thank you for that question. I think it's a big one, and I think the data that I had from the beginning of the presentation is all from the WHO's Future of Nursing, written in 2020. And if you read that whole report, I think it will give you a snapshot of what's needed and what's missing and what we're all working towards. And I think as the International Council of Nurses does a lot of advocacy with different countries, the WHO office, although the WHO nursing office is staff of one, it's a smaller office than all of the other departments. So historically, nursing is under-resourced. And I think even if we think about nurses at UCSF Health, nurses are a cost. Physicians are RVU generating. This is just a mental model, right? That's how we think about medicine. And I think that's what we're working kind of against, but also envisioning something after, where we see investment of nurses as an investment in the health of our population, and where we can see that translating. And I think that's our role in advocacy at the Center for Global Nursing. And I think we have had faculty from all over the world randomly contact me via email saying, I'm a faculty here, I'm isolated, I need support. We definitely see that as an opportunity. We have something to share about that in our afternoon presentation, but I think that's our goal, right, is to work towards creating environments where nurses can help uplift nurses, and where nurses are in a position of leadership and advocacy, where they can work with ministries of health and larger places to advocate for that investment and what that investment would translate into. And I think we're there, and I think we just need to help other folks get there. The big challenge is the number of nurses it takes to make that happen. And I think so it's not a small investment. You want one pediatric surgeon in Lao, you want a second one, it's one person that's got to get trained. But you want to start surgical services, nurses, you need to train them in pre-op, you need to change them inter-op, you need to train them post-op, you need 50 nurses. That's why it's such a big tackle and an investment. And a lot of people steer away from nursing because it's such a big thing to take on.
Quick question. First of all, thank you so much. It's great to see sort of the role of nursing being elevated in a global way, and nurses involved in both agenda setting and prioritization. So keep the work up. Keep up the good work. One sort of point is this issue of access to references and things for our global partners came up a lot in our equitable partnership work, and we have actually negotiated with the library here to approve and allow our academic collaborators and their teams access to the library directly, so they don't have to go through us and say, hey, can you download that? So I just sort of, that's a piece of information for everybody, and I think that that's an important equity step. And then finally, one of the things that I'm really curious about your thoughts on this, but from the bedside to the global leadership agendas, all of that, I find the issues of hierarchies between doctors and nurses comes up everywhere all the time. And I'm really curious what your opinions are about sort of strategies or approaches to start making inroads to that, because I think that that's a really like at every level, an underlying challenge. And I'd love to hear your thoughts on that. Thanks.
Even here at UCSF, every single day, I live under the patriarchy of medicine, as I call it, and I can joke about it, and I feel very confident in who I am and my skills. When I was growing up, my grandfather was like, "You're too smart to become a nurse," and I was like, "Yeah, I got into Harvard, but I'm going to be a nurse because that's how I want to approach care. That's what I believe in, and I'm really proud to be a nurse." But it is. I get not chosen for a lot of things based on my profession, not based on my qualifications, degrees, and experience. And I think I am in this high-income place with a strong voice and a wonderful support system of academic teams. So imagine nurses that I know in all these other countries, some of them aren't even allowed to ask the doctor the question. They're not even allowed to draw labs. That's a doctor's job. You're not qualified to do it. I think it hugely plays in, and there's a lot of data actually in the future of nursing report about there's only, and I think I have this data somewhere, but only 13 countries have more males than female nurses. It's a female-dominated profession, which also plays into it, which is why addressing issues with nursing will hopefully address things with gender equality, which is also one of the Sustainable Development Goals. But I would say that in the work that I'm doing, what we do, especially in critical care education, you can't manage critically ill patients without a nurse. That's excellent. And in critical care, we always teach that whoever has the least amount of skills, whether it's a doctor, whether it's a nurse, whether it's a respiratory therapist, whether it's the lab technician, that will limit the access to care. And so in the education that I've been a part of and the teams that I've been working with, we really focus the WHO BCC class. There's an entire part of the curriculum on teamwork and about hierarchy and so I think when it comes from these higher levels, recognizing the need for the team, we're going to be doing an implementation study with the course asking about interdisciplinary education and respect of your clinicians and looking at that, because I think that is a huge, huge challenge.
Yeah, I don't want to add much, but that's very true. I think it's a problem from country to country, and this is not an issue of just even developing countries. I was in Germany in October, and I was shocked to hear that nurses work like they take the instruction from doctors. They cannot do anything on their own. I was surprised because I was thinking this is a problem more for developing countries. So I think also it's about country, and I think one of the things that I see in the International Council of Nurses is trying to work on, but they are facing a lot of political roadblock because it's like countries are sovereign, their policies and healthcare and everything. So, but I hope that gets better.
And I just think we could keep role modeling, because I just want to say, everybody at IGHS is an incredible supporter of nursing. And as we've started the Center for Global Nursing, I couldn't have imagined a more welcome group of people celebrating and recognizing and being open to learn about nursing from all different sides, all different types of nurses, all different skills of nurses. So I think UCSF is starting to create a great narrative in terms of equality and recognition. And thank you to our leaders and everyone here for that. So,
Thank you very much. This was very instructive, and it was a wonderful grand rounds. Thank you. Remember, what time's the party?
4 o'clock. We're celebrating 1 year.
Is there going to be a cake?
There's going to be sangria.
Sangria. Oh, are we allowed to say that at grand rounds?
Yeah.
Yes. They're 21. They're grad students.
You haven't seen the drug and alcohol-free workplace
Oh.
thing I have to sign.
And it'll be great.
We'll see you there.